Well, good morning. Okay, see, we're starting to warm up a little bit. I want to add my thank you and welcome to all of you for attending, and my congratulations to Roger and APG for this 5th year of the conversation. As I look out in the room and see friends and game changers that have been carrying this conversation, not just for the last 5 years, but really for decades. And I'm reminded that there is no power greater than a community coming together to discover and discuss and grapple with the things it cares about. And so while the future may seem daunting, I feel like we are in good hands because we are enough to figure this out. So it is my great pleasure. We are in for a treat this morning. Ian Morrison, as Roger mentioned, I got to know him a little bit last night. And we're going to have a good time this morning. So let me do the official welcome. This is my bow to getting older. I, too, am getting older, Governor. So Ian is an internationally known author, consultant, and futurist, specializing in long-term forecasting and planning, with particular emphasis on healthcare and the changing business environment. He combines research and consulting skills with an incisive Scottish wit, and I would say thought-provoking conversation. He has written, lectured, and consulted with a wide variety of clients, working for many Fortune 500 companies. He's written lots of books around leading change in healthcare and comments on the future for television, radio, and print media. He's here today to help us shape the future by helping us see it a little bit more clearly. It's going to give us the big picture so that later this afternoon and later in the conference, we can really dig into the issues that are facing Idaho. So please join me in welcoming Ian.
Thanks, Doug. Thank you. Good morning. What a pleasure to be here, and thank you for the kind introduction, Pam. So it's always a delight to come to Idaho. For the last more than 30 years, I've gone every summer to Priest Lake up in the Panhandle and have fond memories. I'm still on the waiting list for an upgrade for my cabin for the first week for 30 years. If you know Hills Resort, it's a popular place. So anytime I get a chance to come to Idaho, I'm always grateful. So I'm a professional futurist. My definition of a futurist is an economist who couldn't handle the calculus. I'm in the sweeping generalization business and have been for a very long time. And the number one question I get asked is, how do you become a futurist? Well, my undergraduate major at Edinburgh University in Scotland was Geographic and Economic Change in Scotland, 1580 to 1830, which is incredibly useful. But it is actually a useful training. I've been a student of structural change in society now for almost 50 years. And there are a lot of lessons to be learned from Scotland's transformation back in the day. But I studied geography and urban planning in the UK. I moved to Canada in the late 70s, and they let me into Canada because I had relatives, but I also had a planning qualification. But they didn't need planners in Vancouver, where I moved to. They needed them in the Yukon, and I didn't really want to go to the Yukon. So I ended up getting a job with Management Engineering Unit 13.1, which was the Canadian healthcare equivalent of the KGB, and spent 7 years in the bowels of an academic medical center trying to understand healthcare. I went back and did my doctorate in health policy and health economics, and then through complete happenstance was offered a job to join the Institute for the Future, the modestly entitled Institute for the Future in Menlo Park, California, to work on a project called Looking Ahead at American Healthcare. And this was for the Robert Wood Johnson Foundation. So I moved to California with my wife and young son. And, basically I've been looking ahead at American healthcare ever since. I ran the health program at the Institute for many years. I was CEO through most of the 90s. But for most of the last 20 years, I've been what I would describe as a free-floating radical. You know, I come in for a day, insult people, and leave. You know, it's like Newt Gingrich, only at a lower price point. But anyway, so I've been doing this a long time, and throughout that 30-year period, I've had a partnership with the Harris Poll and the Harvard School of Public Health, and it's gone through various guises. Basically, every year we survey doctors, consumers, employers, hospital leaders, in some years state legislatures and others. And a couple of years ago, it's a long story, but we basically ended up joining forces with Leavitt Partners. Some of you, I'm sure, know Governor Leavitt, former Health and Human Services Secretary, Governor of Utah, wonderful guy. So we joined forces with them, and so I'm an advisor to Leavitt Partners. I always point out to the governor and his colleagues that I'm an advisor to Leavitt, not a spokesman for Leavitt, so they have plausible deniability if I go off the reservation, which I may do in about 8 minutes. But it's a proud association, and certainly the Leavitt firm has an amazing access to decision makers in Washington on both sides of the aisle, I would say, and I have great regard for the governor and his leadership in healthcare, particularly with regard to the whole value agenda, and we'll talk more about that. So Roger had asked me to talk about innovations Idaho can do right now, and you know, if you want to nod off for half an hour, expand Medicaid, right? I mean, that's a good start. That's kind of I'm totally down with that, and I'll explain why that is the case in a second. But I thought it would be helpful to give you, as Pam suggested, a kind of a 30,000-foot view of what I'm seeing and hearing in my travels. And I work with everybody in healthcare from Kaiser to Pfizer, I mean, literally. And so spend a good deal of my time in rooms like this across the country, whether it be you know, multiple stakeholders like a room like this, or whether it's boards or retreats for individual institutions or companies, and can give you maybe a sense of what's keeping people up at night in various parts of the health ecosystem. So that's kind of what I thought I'd talk about, and look ahead perhaps at politics and policy in terms of the driving force for change and disruption in many instances. Talk a little bit about consolidation and disruption that's happening in various parts of the industry. The governor was very eloquent talking about the plight of Idahoans in terms of their healthcare coverage, and they're not alone. It is a mega trend, if you like, that consumers are feeling this thing of healthcare. That's why I refer to them as shallow-pocketed consumers, and I'll go into some detail on that. He also invoked employers and noting that this is a state more dominated by small employers rather than large employers. But employers generally are the financial lifeblood of American healthcare. They pay way more than the cost of care to subsidize quote unquote, the underpayment by Medicare and Medicaid. And we'll get into that in a little bit of detail in terms of where they are and where they're headed. We're also seeing considerable angst amongst physicians. And, you know, burnout is epidemic amongst doctors. Suicide rates are all-time highs. It's a very disturbing picture. And I think it's not just burnout, it's demoralization. And we should think a little bit about how doctors are feeling and how they're changing in terms of how they're organized. And obviously, this state, like many states I visit, has particular challenges with rural health. So I'll give you my 30,000-foot view on rural health, although I wouldn't consider myself an expert. And then I'd have to give my futurist license back if I didn't sort of speculate a little bit about the end game and some of the possible scenarios that you might have to encounter going forwards. And I'll close with some thoughts, with some humility, I have to say, about what you can do right now. So does that seem like a sensible way to spend an hour? Good, because that's the slides I brought. So merciful. So let me just start with kind of an obvious statement, which is that there are only three payers for healthcare. The money either comes from business, government, or households. But fundamentally, it all comes from households. You either get it through foregone income at work. People often say, my employer gives me health insurance. No, they don't. It's your money. It's part of your compensation. They'd have to give you a different deal if they didn't have health insurance. It just happens to be a very tax-efficient way of paying you, particularly if you're upper income, right? So business is one source. You can pay for it through taxes, or you can pay for it directly in terms of out-of-pocket costs. Now, if there's one data point to remember, and then you can go to have a wee nod off for a minute or two, here's a statement I always make to every audience. The average American family cannot afford the average health insurance premium. You think about that for 8 nanoseconds, that's a wee bit of a problem, right? The average French family can afford the average premium because it costs half as much and they make about the same. So median household income this year in America will be about $62,000. Median PPO policy for a family of 4 is $19,000. That does not include out-of-pocket costs. If you include out-of-pocket costs, you're talking about $28,000. Does not compute. And that is why the bottom half of the income distribution, any household earning less than 62 grand, theoretically really needs a subsidy to be able to afford health insurance. And that's why we're seeing Medicaid expansion. That's why we saw the Affordable Care Act. It was in response to the fact that the bottom half of the income distribution can't afford the product. The other thing, and we'll get into some more depth, is the people above that are also feeling the sting, but I'll explore that in a bit more detail in a second. So if you think about what we've done over the last 10 years, we had a big national debate about the Affordable Care Act, Obamacare. And a lot of that was centered around the little sliver at the top of this chart, the 20 million people who were in the individual market. Now, the individual market was awful before Obamacare. I was in it. I was denied coverage in California by Blue Shield 3 times before Obamacare provisions kicked in. The reason Blue Shield denied me, they told me I was a Honda, hypertensive, obese, non-compliant, diabetic, alcoholic, right? Now, none of that is true, but is directionally correct, okay? But if you go back to the pre-Obamacare days, 50% of people who try to buy insurance in the individual market were denied. Either flat out denied because they had pre-existing conditions, or they couldn't afford a rated policy, right? Now, the people who were covered, the medically underwritten, their premiums went up. And President Obama should have explained that to people. By definition, when you start to community rate the sick people and the well people, the premiums for the well people is going to go up, right? That was like and was not explained. And those are the groups, the people who were often small business people, Rotary Club members, conservatives, older people, retirees, self-employed people. They saw their premiums go up. But the big story, in my view, of Obamacare was Medicaid expansion. Because in my travels, if you go to states that expanded Medicaid, you saw a very significant difference in the way in which healthcare was covered. And the number of people covered by Medicaid was 2, 3, 4, 5 times as much as the increment in coverage through exchanges, depending on which state you go to for various reasons. So Medicaid expansion became a very important part. And there was a good news and bad news to this if you're in a provider system. In a state like Oregon, bad debt for inpatients went down from 6% of revenue to 4%, like that, okay? At the same time, those hospitals saw a permanent impairment in their payer mix towards Medicaid being a bigger share of their revenues. And that's the story across the country, and sort of explains why in aggregate, we've seen a lot of health systems margins decline, because they've gone from 15% Medicaid to 20%. And that, I think, is the sort of mixed blessing, if you like, if you're a provider, from Medicaid expansion. The other big story that's often missed is the relentless rise in Medicare Advantage. But as I'll show you in a second, about a third of all Medicare recipients are in Medicare Advantage, and that has risen despite the fact that Democrats tend to not favor it very as aggressively as Republican politicians do, because they see it more as a payoff to the insurance industry. But no matter what, we've seen Medicare Advantage rise across the country. And again, I'll hammer this point over and over again, employer-sponsored coverage is the lifeblood. And let's note here the 150-odd million people who get health insurance at work. And it's important to gauge their interests in losing that and changing the circumstances of it. And I'll talk a bit about where the public is in that regard. So I mentioned Medicare Advantage. We're up around a third of all recipients of Medicare who are in Medicare Advantage. It grows relentlessly. Many of us believe that we'll go over 50% within the next decade, and that could be a tipping point in terms of value-based purchasing, which really is one of the key drivers, in my view, of transformation in healthcare delivery. And by the way, and we'll get into this in a bit more detail in a second, the private equity people, the sort of venture capital money that's flooding into new Medicare Advantage startups is quite dramatic. And it is not just established players like the Blues and United who are in this game, but there's a lot of money floating around supporting innovators in that space, and we can talk more about that. You in Idaho are about the national average in terms of penetration of Medicare Advantage, about a third. There are states like California and Minnesota, parts of Pennsylvania, parts of Florida, where it's even higher than that. But I would predict that you would see continued relentless growth in Medicare Advantage in this state, as we will in virtually all others. And you know this story well. You've gone through a political debate in this state, as several states have in the last 2018 election, around whether or not Medicaid should be expanded. Your state voted, I believe it was 61 to 29, or 39 rather, in favor of Proposition 2. That's almost exactly the same margin as happened in both Utah and Nebraska. And while there have been legal challenges and different permutations of this suggested by governors and by state legislatures, I believe, as the governor sort of affirmed, that we're going to see those states expand Medicaid going forward. It came within a whisper a month or so ago in Kansas, with just a couple of state legislatures missing. They now have a Democratic governor who's committed to expanding Medicaid. And I've worked with every state hospital association pretty much across the country, and I can guarantee you the official position of the Missouri Hospital Association, the Tennessee Hospital Association, and North Carolina is to expand Medicaid when they get the political opportunity to do it. And often the resistance is not the population, as evidenced by these plebiscites, but is the state legislatures, who tend to be way more conservative than the average citizen in many states across the country. Now, why should we focus so much on Medicaid expansion? Because it matters, and it matters in terms of who ends up being uninsured. If you look at the very granular level of the county level of uninsured in America, this is 2016 data, but it was a report that the Census Bureau produced in 2018. I'm a survey junkie. You can't do this with a Gallup survey or a Harris survey because you need massive samples to be able to get to the county level, and only the census can pull it off. So what this chart shows is the percent of population under age 65 who are uninsured. So if it lights up blue, you have a lot of uninsured. And you can see Texas in particular, Oklahoma, being very high. But if you focus on a subset of that population, it gets even more dramatic, which is working age adults below 138% of the federal poverty level. And you can see the impact of Medicaid not being expanded. Those states in the South had very, very strict, as you do, relatively strict eligibility requirements for Medicaid before Medicaid expansion. And that's one of the reasons why you see these extreme differences between expansion states, say in the Northeast and the Southeast of the United States. So it matters in terms of coverage. Now, you could debate whether coverage actually leads to care. The best studies are showing, yes, it does. Does it affect health status? Not yet, but some studies would say it has actually reduced mortality amongst people who got Medicaid. Some people would argue it's certainly improved the financial circumstances of people who got Medicaid, and others would argue that the evidence shows that behavioral health has improved dramatically for those who got Medicaid coverage. But nevertheless, I would argue that if you look holistically at all of the research evidence, expanding Medicaid is a good thing to do for your state. Now, I have been consistent for the last 2 years in arguing that repeal and replace is like breaking up the Beatles, where you just keep George and Ringo and expect it to sound good, okay? It turns out that John and Paul are quite important, okay? So you've got to raise, I mean, if you start with the premise that I started with, that the bottom half of the income distribution can't afford the product we're selling, you've got to raise money to support the subsidies that are necessary to expand Medicaid or to provide exchange subsidies for lower income people. So you need John and you need Paul. Now, ironically, we have basically not implemented most of the taxes in the Affordable Care Act. No insurance tax has been implemented, no Cadillac tax, no medical device tax. They've all been postponed. The only tax that's in place is the supplementary tax on higher income folk. But most of the subsidies are still rocking and rolling along, right? And then everybody loved George. He was always underrated. Guaranteed issuance was really what the 2018 election was about at the congressional level. Americans' consensus now is they do not want a system which takes away the protection for pre-existing conditions. And of course, everyone loved Ringo from day one. You know, staying on your parents' plan was very popular with the American public. By the way, I had a very simple idea to solve the healthcare crisis, which is you stay on your parents' plan till you turn 65. It would have worked like a hot damn, right? So a week after the election, I was moderating a panel in Washington. I don't go to Washington that much, but I've been going a lot more recently. But and Chris Jennings was on the panel. Chris, if you may know, is a distinguished Democratic healthcare advisor. He was Hillary Clinton's advisor. I mean, I would have been curled up under a blanket the week after the election if I was him, but he was gracious enough to be on the panel. And he liked my Beatles metaphor, and he said, you know, when they're done with this, all you're going to be left with is Ringo. And, you know, if you think about it, by the way, I'm a former drummer. That's a very bad place to be, is being left with just Ringo. But if I could quote my favorite author myself, I wrote shortly after the election in a piece about protecting California's healthcare expansion that Republican policies are ideologically coherent, they just aren't actuarially coherent. Now, I didn't say that to be mean or partisan. It's just that if you looked at what happened in successive rounds of proposals by the Republican Congress over the last couple of years, all of the proposals, when evaluated by the Congressional Budget Office, showed fewer people covered and higher cost for doing that going forward. So they didn't perform actuarially as well as existing law as in the Affordable Care Act. And I like to think that was part of the logic behind John McCain's thumbs down that basically killed, at least for the short run, repeal and replace activity in Washington. Now, that doesn't mean that we aren't seeing changes in the Trump administration in the way in which they have managed and implemented the Affordable Care Act. And the two vehicles have been the use of executive orders and the use of waiver authority granted to the Secretary. And I won't go through all of this, but you see this both at the federal level and at the state level, where things like association health plans, short-term plans, essential benefit provisions being attacked or eroded, depending on what your politics are. Work requirements is a very common debate. These are what I would say, and Governor Leavitt used this phrase as well, as sort of ideological forms of repeal and replace, using executive orders, waiver authority, and interpretation of the law in a different political lens, right? And that's what's been going on across the country. You'll notice, however, and this has happened to you all too, is that the courts have sort of pushed back against some of the rollbacks of these provisions. And that's why healthcare, I think, is going to be a central issue in the 2020 election. That's kind of a duh statement, but it is a political football for the next to 4 years as we figure out which direction the country will take. So we developed with our colleagues at Levitt a series of scenarios. These are like little stories about what may happen, and there's a whole series of verbatim behind it. But let me just give you the sketch map version. The scenario we're living in right now is the ACA lives on in Republican hands. It's that ideological repeal and replace where it's sort of a half-hearted commitment to it in regard to coverage expansion, cut things like promotion of exchanges at the federal level quite substantially. But nevertheless, you saw about the same number of Americans in exchanges by the end of for the 2019 season as was last year. If we are to move to the right, and a scenario that we labeled unbridled market principles, and this has been signaled in budgets that have been put forward by the president and proposals that have floated around in Congress to basically get rid of, repeal and replace, and the replace would look like block grants for Medicaid. By the way, when you hear the word block grant, it's code for less money, right? People say, well, I get flexibility. Flexibility without money is not flexibility, in my humble opinion, right? If it goes to the left, and we're seeing signals of this already, is what we call Marylandish for all. And Maryland, as you know, has been an all-payer rate-setting state. In the last year, they moving from just hospital price under an all-payer rate setting to total cost of care. And I think that's a sort of signal event. You'll notice in the state of Washington, they introduced in the last couple of weeks a public option proposal, which expands the population who have access to Medicaid pricing. That's the key, right? I call it the warm comfort of Medicare pricing. And I'll show you why I think that's a significant trend to watch. So we're going to get the Democrats all fighting to do Medicare for all, but I think where we might end up is Medicare for more, right? That's a different animal. It's not total replacement, but more populations having access to Medicare or Medicaid level of pricing. And that's very significant if you're in the provider business. Now, what Governor Levitt has been preaching, and I completely agree with, is that we ought to have a bipartisan support for a value-driven system that rewards value in healthcare and doesn't just simply pay for volume. It's something I've preached over my career too, and one of the reasons why we joined forces is I think even though we may come from slightly different political traditions, we're in alignment on that fact that that would be a better outcome for the country if we could find a sustainable, long-term, bipartisan solution centered around value, centered around managed Medicaid, and around Medicare Advantage as the core of public programs. So why are we seeing such angst in the American public around the healthcare more broadly, given that most people are expanding Medicaid? And if you don't live in Texas, Florida, or Georgia, you're kind of on the path to coverage expansion. Why is this still such a big deal? Well, I think it's a big deal because of this very simple question that we ask the American public. We've been tracking this question for some considerable time, both when we were with Nielsen and Harris and now with Levitt Partners. And the question is, asking consumers now, overall, how well does your health insurance plan meet your family's needs? Now, we don't ask this question of the uninsured. That would be cruel, right? How well is your insurance working is not a thing you want to ask the uninsured. But you'll notice here a couple of things. It's a hard slide to read, but you want to be dark blue or light blue. Extremely or very well, right, would be a good response. Two things. One is a big drop in 1 year, okay, from 2017 to 2018, a 14% drop in the top box of extremely well. That you don't see that in surveys. These things don't change. I hate satisfaction surveys, by the way. And the reason I hate them is they don't change. We've been doing this for 30 years. I mean, the Americans, look, the reason why, Americans are nice people, right? They're happy with everything. You want to see dissatisfaction? Go survey the French, right? They're pissed off about everything, right? So Americans are generally happy. That's why if you've got, if you're getting 80% saying they're satisfied with their care experience, forget it. I discount that. We came up with a scale which measured people who are saying, a third of Americans are powerless, depressed, and angry when they're dealing with the health system on an emotional scale. That's the real way to measure this stuff, not the happy face. Hi, my name's Bob. I'll be your surgeon today. But anyway, that's another rant. The other point I want to make here is if you look at the type of insurance and you break people out by type of insurance, the worst place to be is in the individual market without subsidy, right? Off exchange, off subsidy, and people who don't qualify for subsidies that is the worst place to be. The second worst place to be is in the exchange with a subsidy. The third worst place to be is employer-sponsored coverage. And I'll explain why I think that is happening in a moment. But people who are on Medicare and Medicaid of various flavors, managed or not, are relatively happy compared to those on employer-sponsored coverage. People say to me all the time, well, Medicaid is a failing program. No, if you're on it, it's not. Compared to being uninsured, are you kidding me? It's first dollar coverage. Because the real source of angst behind people with employer-sponsored coverage is you can lose it and you're paying way more for it than you did 10 years ago, right? It's out-of-pocket costs and it's vulnerability. If you change jobs, you could be in deep trouble. And that's what's coming out in poll after poll, survey after survey, study after study. This is from the Kaiser Family Foundation. Just a couple of weeks ago came out. So if you see that big blue bar, 14%, that big blue bar on the left, that is for those people earning less than 200% the federal poverty level, which is like about 40 grand for a family of four. They're paying 14% if they have health insurance at work. And these are working people. These aren't people in Medicaid. They're paying 14% of their income towards health care in the form of deductibles, co-pays, and their share of premium. And that we have a system that is regressively financed, not progressively financed, and that's where the worst place to be is a working person with health insurance in a high deductible world, right, of low income. That's the vulnerable spot. The other vulnerable, and you see this in other measures, Commonwealth Fund has been tracking this for more than 15 years. And amongst people with employer-sponsored coverage, significant rise in the percent who have out-of-pocket medical expenses exceeding 10 or 5% of their income, whatever the metric is. And basically a doubling of that percentage over the last decade or so. And I mentioned this notion of vulnerability. People forget how dynamic the U.S. economy is in terms of change. You get a job, you lose a job. It's much, much more dynamic than almost any other economy, and significant churn, particularly in small business. And that's, again, the vulnerability of employer-sponsored coverage. And we find in surveys even to the point where if you ask people, a question, my health condition makes it difficult to take care of myself, and you look at that by insurance coverage, amongst those people with 3+ chronic conditions, you see a big rise, relatively speaking, in the angst felt by those with employer-sponsored coverage. So why don't we just do single payer? Well, the short version is we don't have enough money. This is before the tax cut. This is the number forecast for healthcare programs, federal healthcare programs, right, as a share of GDP, going up. That big, bright blue wedge in the middle getting bigger and bigger. This is not Obamacare. This is Medicare. This is 80 million baby boomers going through total body breakdown simultaneously, right? And we're all going to be sitting around in nursing homes singing "I Got You, Babe" to each other. It's going to be profoundly unpleasant, So that's what's really driving that wedge going up. And think about what we've done over the last couple of years as a country. We cut government revenues substantially in the tax bill. We raised government spending in the last 2 rounds of budgets over the last 2 years. We are running trillion-dollar deficits as far as the eye can see, and we started a global trade war, right? It's really tough to get John Maynard Keynes and Adam Smith rolling over in their graves simultaneously, but we managed to do it, right? So we basically have dug ourselves an enormous fiscal hole going forward that I think is going to be the dark shadow over healthcare. I'm kind of like a demotivational speaker when I think of myself. So are we going to do single payer? Well, let me just say the short version of this is probably not. And the reason I say that is you're not Canadian, right? I'm married to a Canadian. I lived in Canada. I trained in Canada. Half my family gets care in Canada. You're not Canadian. Canadians describe themselves as unarmed Americans with health insurance, right? It's culturally very, very different, right? And a single-payer system a la Canada is a massive transfer of income from rich people to poor people, right? We did it the other way around. We just cut taxes on rich people. So it's inconceivable to me that as an American populist that we're going to pull the trigger for 70% marginal tax rates to sustain this. Now, does that mean we're not going to expand populations with access to Medicare pricing? No. Could we see states expand Medicaid substantially and maybe even allow other populations in? No, I think that's quite likely. But I think we've got to be careful about what I would call a simple, seductive solution of a single-payer system. And the other reason why, that's another lecture about why we're different from other countries and where the cost differences are, and I'm happy to answer any questions on that. But one of the fundamental differences between the US and other countries is almost every other country I know, and they all have different flavors of how they run their health system. If you think about what we do is we squeeze on the balloon somewhere and it pops out somewhere else. We cut Medicare budgets or Medicare reimbursement rates, and you raise prices on self-insured employers, right? That's a balloon-type response. What they do in other countries is they put the balloon in a box and they sit on the box, right? So they have total cost of care targets de facto because they are managing to a share of GNP, right, from the top down. We are really reluctant to do that in the US, although some states, as Massachusetts is a good example, has actually put in place a voluntary kind of balloon in a box model, right? Where they're agreed, multi-stakeholders agreeing to keep to a target that's tied to growth in state GNP per capita. And we in California are playing with that in policy circles right now. So where is single payer on the polling scale? If you just ask a simple question, are you in favor of giving people a choice to get into this game, you see quite high proportions, both of Democrats and Republicans, saying, hey, I'll do it. You know, if it's a choice, if I can get access to Medicare, why not? But the polls show quite clearly that once you start putting consequences in front of respondents, like you're going to lose your employer-sponsored coverage, or you're going to pay more in taxes, or it could threaten the current Medicare program, then you see support drop off quite dramatically. And I think that's really what we're going to see in the next debate. The Democrats are going to out-left each other through the primaries, trying to say, I'm more liberal than you are, and then they're going to have to go to a general electorate with some kind of proposal that is solving healthcare to some degree. I don't think they'll be able to stand a platform and win on a pure Canadian-style single-payer system, but I may be dead wrong. I've been dead wrong before. What I would bet money on is that pressure from both conservative points of view and liberal points of view will continue to put focus on prices and commercial prices. And this is really addressing both the insurers and providers in the room. So RAND came out with a study in the last 2 weeks that is reflected here. They took all-payer data from 25 states and looked, and this is looking at employer-sponsored coverage here in terms of the prices, not the charges. This is nothing to do with ChargeMaster. This is what was actually paid to those institutions on inpatient and outpatient basis. And there's 69 health systems. And by the way, in the appendix, they actually name names of who these people are. On average, providers are charging, if you blend outpatient and inpatient, are charging 241% of Medicare across these 25 states. A study just came out from the West Foundation yesterday on California numbers. We're around 209% using the same methodology, 209% compared to Medicare. Ironically, states like Massachusetts, New York, and California are lower percentage-wise, and I think it's partly because they have a lot more generous Medicare and Medicaid reimbursement, not in the case of California, but certainly in the case of Massachusetts. And the story varies by state. You've got some states like Indiana and Colorado who are high and getting higher, and you've got some states like Michigan, which is going down. Pardon the pun, yes. Hadn't thought about that. It's pretty funny. So, look, the game, if you run a hospital, this is what keeps you up at night if you're a CFO, right? It's this chart. It's underpayment, quote, and I put it in air quotes because CFOs say this to me all the time. Medicare underpays me the cost of care, and I say, no, let's put it another way. Medicare pays you a rate that doesn't meet the income aspirations of you and your people for doing things the way you're doing it right now. That doesn't sound quite so noble, right? So change the way you do what you do, is my response. I mean, like every other industry had to do over the last 30 years. We're the only, the other industry is higher education, with all due respect to Boise State people. Those are the two industries with rapidly escalating prices that have not gone through the forces that have affected every other industry. So, on the public policy side, what to expect? I would prepare for less financial support from DC for Medicaid and exchanges. It's not that it's going to go down, it's just that the relative generosity may be challenged by the fiscal environment. And that is true of Medicare and Medicaid reimbursement rates going forward. I think you're going to see more scrutiny and focus on commercial prices, both politically and managerially by payers. I think there's going to be more belt tightening in the ecosystem. I think you're going to see weaker players capitulate, and that will lead to continued consolidation. I think it's really important to understand there is an enormous difference between Secretary Azar and Secretary Price. Tom Price was an orthopedic surgeon who thought value-based care was a waste of time. Azar is a protege of Governor Leavitt's and is a believer, as is Adam Baylor, head of CMMI, in advancing rapidly value-based payment, and I think you can expect that under any administration now going forward. If you're in a blue state like I am, we worry a little bit about losing what we got, right, which is California is getting $20 billion a year of net new money post-Obamacare to cover both Medicaid and insurance exchange expansion, right? Our Medi-Cal budget this year is $99 billion, right? That's bigger than the GNP of most countries. If you're in a red state, you're going to see more red states expand Medicaid, I think, unless there is a landslide Trump victory with a massive majority in the Senate and House on the Republican side. So we're going to have another political debate, another round of this. And as I said, the dream on the right, I think, is sort of a block grant future. The dream on the left is more people getting the warm comfort of Medicare prices. What will not change, in my view, is the necessity of both parties to use the instrument of value-based purchasing. And I think the rhetoric is ahead of the reality. Everybody's got the same PowerPoint slides. Leavitt does a very good job of tracking a lot of these activities, things like ACOs we'll talk a little bit about. I draw a sharp line, as they do, between the initiatives on the left of fee-for-service, care management, pay-for-performance. To me, until you get downside risk, it's what I call fee-for-service with tricks, right? More is better, Same with bundles. Bundles are great, but more bundles, more money, right? It's still fundamentally a fee-for-service and a volume incentive. It's only when you get to downside risk that you have to think twice about the frequency with which you're doing things, right? That, to me, is the sharp line in terms of value-based payment. And while it's true, if you look at the measured sort of penetration of value-based initiatives, we're up over 50%, blah, 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 that's not true in terms of two-sided risk or capitation. We're not there yet, and it's hard work. Look, I've worked with Kaiser for 30 years. It is unequivocal at Kaiser what they're trying to do. They are trying to keep people out of the hospital. There is no mixed signal. It's about keeping people out of the hospital. That's not true necessarily in some of these other models. So we've seen growth in ACOs over time. We're up around 10% of the US population covered by an ACO. If you add on Medicare Advantage onto that, and you add on all the commercial payment, because there's probably twice as many, according to the Levitt folk, lives in commercial ACO type arrangements as in Medicare, and they continue to grow. Now, you could argue, well, how successful have they been in saving costs and improving quality? It's underwhelming, to be perfectly frank. I have been a supportive critic of the ACO movement since the beginning, and my rationale is, compared to what? Doing nothing? I mean, yeah, it's better. I've always viewed it as kind of training wheels for capitation, is to try and get you in the game of taking risk. And there's some evidence that in the aggregate, it has helped sort of dampen down the increased utilization that is inherent in any fee-for-service type set of incentives. So I think it's been a force for good, but it is underwhelming in terms of its over impact. If you look at, we're not saving 20% costs and improving quality by 20%. There may be isolated examples of that, but I think it's a much more muted situation. I think Medicare Advantage, on the other hand, often shows pretty dramatic impacts on the utilization of hospitals. All right, let me take a few minutes, and I do want to make sure I'm watching the time here. Roger, we're doing okay. I do want to take some time so that my measure of performance is violent disagreement, so I'll keep insulting you till I get a response. But I do want to spend some time on sort of the private sector initiatives going on. So I go to a lot of meetings. I chair a lot of meetings, moderate a lot of meetings, speak at a lot of meetings. And I can't tell you the number of meetings I've gone to with basically the theme of disrupt or be disrupted, right? Gatherings of the wise people. Why is it going on right now? Well, partly it's because private equity investment in healthcare and venture capital investment in healthcare is at an all-time high. I live in Menlo Park, California, which is ground zero of Facebook, Google, venture capital, and I'm involved with a couple of private equity firms in healthcare, and they are at all-time highs. I mean, and these guys, if you talk to them, they don't come in with a preset. They basically think this is a brain-dead industry, right? That it moves at the speed of glacial erosion, and we can do better. There's a certain arrogance to it. They call me up and they go, Ian, I'm going to disrupt healthcare. And I point out to them, the American healthcare system is larger than the entire Italian economy and about as well organized, right? So when you say you're going to disrupt healthcare, it's like saying you're going to disrupt Italy. Good luck with that. This industry has shown an amazing ability to resist change. But I think there's so much money being thrown at this stuff, some of it is going to have an effect. Plus, you've got all these big corporate mergers, and we'll talk about a couple of them, and at the same time, continued consolidation in the nonprofit hospital and health delivery system. So those are important drivers. Then couple that to the massive and relentless transformation to the ambulatory environment. Most hospital systems get more of the revenue on the ambulatory side than they do on the inpatient side. Those lines crossed over in the last couple of years. And as I laid out, more and more Americans are seeing higher out-of-pocket costs. So you have this enormous burgeoning retail opportunity to deliver services where it's coming out of the consumer's pocket and they're not really covered, right? That's fueling a lot of activity. The other thing to note is that the growth of pharma relative to inpatient costs. So in every insurance plan I work with, commercial insurance plan I work with, pharma spending per member per month exceeds inpatient hospital spending per member per month. Those lines crossed over in about 2014 for most people I talk to. And there's a lot of people in the life sciences business who think that we're in a massive shift away from the traditional primary care and acute care treatment to a prediction and cure paradigm. You do a test, you find out you have Hep C, you get a drug, it disappears, right? That's a little bit fanciful, but I think is directionally where much of the investment in that industry is headed. And then there's all these technology enablers in terms of artificial intelligence, machine learning, mobile, cloud, blockchain, on, all coming together at the same time to create a platform that's possible to transform healthcare delivery. And then there's fear of new entrants. If you really want to make a living as a healthcare consultant these days, all you have to do is say Amazon and healthcare in the same sentence, you're hired, right? And that basically is not a joke, it's almost true. You've got to keep an eye on these guys, and we'll get into that in a little second. And then you've got the fundamental driver of an aging society with insufficient assets. That 80 million baby boom group, half of them have no money. And how's that all going to work out? And what kind of innovations will be needed? And a big driver of change is the rise of consumerism. So you're familiar with some of the mergers that you hear about in the papers and in the trade press. Common Spirit is the combination of Dignity and CHI, creating a $28 billion multi-state system. You're seeing a lot more regional consolidations like Advocate and Aurora in the Midwest, or the Wake Forest Atrium combination in North Carolina. You're seeing mergers between traditional players like Centene acquiring WellCare, making a almost $100 billion run rate company in the Medicaid and exchange space. You've seen the CVS Aetna acquisition. I'm pretty close to the CVS guys. You saw Optum buy back from DaVita, Bob Margolis's Healthcare Partners business, which is a really interesting move. And you saw Cigna acquiring Express Scripts. All of these are big bets, right? I mean, these are massive, massive transactions, certainly the ones on the bottom. Not the Optum one so much, but the other two. And of course, you all know this, that more and more systems more and more hospitals are in systems over time, and independent institutions are challenged. I said this, and I don't want to overplay this, but I said this several times already, the importance of employers. So let me just quickly take you through how I think about the employers. And bearing in mind that the self-insured employers, the big guys, nationally, of the people who have private health insurance, 60% of them are self-insured, right? That number's probably a little lower in this state, but I can't imagine it's that much lower, just in terms of the distribution of employment. So we mentioned the numbers, the Millman Medical Index, which includes out-of-pocket costs. The 2018 number was $28,000 a year for a family. If you look at the Kaiser Family Foundation numbers, which excludes out-of-pocket costs, we're up around 20 grand, with the distribution paid partly by employers and partly by workers. The important thing to note over the last decade is that the rate of increase in terms of what is paid by the worker has gone up faster than the rate of increase of what's paid by the employer, right? That yellow line's above the red line, meaning there's been kind of a cost shift to employees, and that makes sense when you think about it, because what we've seen is the rise of deductibles, right? I mean, almost all of you in this room, I'll guarantee you, have seen your deductible go up. So we're now at a situation where 26% of all workers have a deductible of $2,000 or more. If you're in small businesses, 42%. Now, why is that relevant? Well, because most people don't have 2,000 in financial liquid assets. This is a well-heeled crowd, but let me tell you, the Federal Reserve tracks this stuff. 37% of American households couldn't come up with $400 for an emergency room bill. That's not me making that up. That's the Federal Reserve, right? And most Americans live paycheck to paycheck at surprisingly high income levels. So you gleefully send them a bill for a $5,000 ride through an MRI. They got to sell their car if they were going to actually pay that. And that's the situation I think that's fueling a lot of angst amongst the American middle class. And the other thing to note is that the percent of Americans with employer-sponsored coverage is not going up, it's going down, right? And this isn't Obama. People like to blame Obama. This is the progressive unaffordability of American healthcare, right? And there are two factors going on here, principal. One is it gets progressively unaffordable, so small business doesn't even offer it. And even if they offer it, the low-income workers can't afford to take up their share of it, right? It's offer rates and take-up rates going down over time. And the other phenomenon is that there's a lot of people who work at Google. There's not a lot of people work for Google, right? Google is unbelievably meritocratic, right? So they have red badges and green badges. If you're a green badge person, and you might be doing exactly the same job, if you're a green badge person, you're anointed, you get the free everything, you get, the health benefits, blah, da-da. If you're a red badge person, you're a 1099 contractor. And that's a very different game, and that's the way they roll, and you got to earn your right to get that green badge through excellent performance and so forth. And that's the way Silicon Valley rolls increasingly. So are employers going to abandon health insurance? And we've been passionately tracking this for over a decade now. And let me just talk you through, and that we're surveying not employees here, but we're employers, right? We're benefit managed decision makers. So the green line at the top is the percent of employers who say it's our responsibility to ensure our employees' health needs are met, right? That's why I say the good news is they're not leaving. The bad news is they're not leaving, right? And that means they're going to be more in your face and more aggressive. Because if you look at the line, the orange line there, employer-based health insurance will soon become a thing of the past. That's just over 50% of employers agree with that statement. The second one is the one I always think that's interesting. My company is actively exploring ways to get out of providing health insurance to our employees. That went up. People took a look at it in the Obama years, did the math. The math was not compelling. It came back down. Trump got elected, talked about doing something different. They took another look at it, went back up. The math was still not compelling because of repeal and replace, came back down. But this says to me and to us that this is not a blood oath that they're going to hang in there forever. This is probationary, right? They could leave. And you want to see people get really excited, you talk to a group of CFOs, not healthcare CFOs, real CFOs of other companies. Sorry, but I didn't mean it that way. Non-healthcare CFOs. And you explain to them they could write a check for $10,000 and be done with this. They get verklempt. I mean, they get misty-eyed. They think it's, oh my God, that would be unbelievable. So I think this is conditional. I think it's probationary. But the ones who are staying are going to be in your face. And I mentioned I invoked consumerism a couple of times here, and I want to just make a couple of comments on this, and then we'll talk sort of scenarios and leaves time for questions. People talk about consumerism if it's one thing. I think it's 5 things, and they're related, but they're not the same. One is the rise of transparency and consumer navigation tools. Transparency on prices and quality and shopping around. Now, there is precious little evidence that Americans do that. I mean, Aetna's got a very sophisticated tool. 1% of members actually use it. And it's partly because the data are useless, right? It doesn't tell you what you want to know. I had spinal fusion done at Stanford. I could care less what percent of patients had aspirin on discharge. I've got aspirin at home. It's not particularly helpful. I was having my throat cut by a neurosurgeon. I want to know his batting average for that procedure, right? That's the data that's missing from a lot of this consumer-directed stuff. So we've got to get better at that. Consumer experience matters because there's money attached. If you're a health plan in the Medicare Advantage business, it's all about being 4 or 5 star, right? If you're a hospital in value-based purchasing, you've got to improve your CAP scores to get the money. But the real driver, certainly the driver for Silicon Valley, is this notion of higher expectations of service industry. And how do you run your life? You run it off your phone, right? Everybody does. I'm just talking millennials. We all do, you know. I'll walk out this hotel or the hotel later on this afternoon, press a button on my phone, and some lovely person from Morocco in a Toyota Camry will take me to the airport, right? This is Uber, by the way. I don't have a weird lifestyle, but anyway. That's how we roll. That's how we all do what we do. Then you have to deal with the healthcare system where people are scribbling notes on whiteboards and faxing things to each other. The fax machine should have been out of business 30 years ago. And yet that's how we communicate in healthcare. Michael Howell, who's now at Google, who was at the University of Chicago, a distinguished physician, told me this. He said they actually have courses now for first-year medical students to teach them how to use a fax machine. Otherwise, they wouldn't be able to function in a typical American hospital. That is positively medieval, in my view, and is one of the reasons fueling change in healthcare. The other big consumer dimension, which I don't think we've got a handle on yet, is how do we change behavior? How do we get people to smarten up and do the right thing? We all know what to do. You walk, you drink less, and you eat less, and you exercise. It's not complicated. It's just getting people to do it is incredibly difficult. But the big driver of consumerism, as I think I've indicated, is rising out-of-pocket costs. So how's this all working for doctors? Well, I think in our surveys and in most of the surveys that have been done by Mayo Clinic and others, 56% of docs say they're burned out. And the things that cause them angst, we've been tracking for a long time, include their EMRs. By the way, that's the single biggest predictor of dissatisfaction is if you hate your EMR, right? That's why so many. How many systems here are using scribes? Interesting. Just a few? Yeah. I mean, it's quite prevalent now in the industry. This is again, that's medieval. You have a serf who, trots behind the knight and fills out the electronic health record for them. But doctors hate high deductible plans. They hate malpractice. They hate health insurers. They hate CMS. They're actually not that big a fan of the AMA. I'm going to a big meeting next week with the AMA, and I never showed Jim Madeira, who is CEO, this slide. And they're not that thrilled with even biotech, which was one of their darlings in the past. So in terms of their ability to help quality. So doctors are in a bind and I think needs support. And I think it's one of the reasons why we're seeing this angst in the field, because an increasing proportion of physicians, as you know, it's up around 30% now in the 2018 survey that just came out a couple of weeks ago, work for hospital-owned practice. And by the way, who are massively subsidizing those doctors. I mean, we're talking, I was with a group of CEOs in Washington last week. They were saying, I said, so what's the average you're subsidizing these employed docs, 100 grand a head? Oh, more like 300 for some of the specialties. I mean, there are big numbers going on across the country. And we're seeing doctors organize in different ways, not just aligning with hospitals. One Medical, which is a concierge practice out of San Francisco and Boston and a few other markets, is growing like wildfire. Amir Rubin, who was at Stanford and then at Optum and is now CEO of One Medical, is a good friend of mine. They're doing really well, and one of the ways they're selling this concierge practice for millennials is to basically go directly to Google, say, you pay the subscription. And they're also going to health systems to say, look, we know how to run primary care practices with net promoter scores in the 90s, let us take over your primary care function. So they're doing really well. Oak Street Health is in the Midwest is a high needs, vulnerable, elderly focused, dual eligible population with a completely different delivery system. And there's all kinds of private equity money flowing into systems like that are dedicated delivery systems for frail elderly, taking full risk and capitation. Optum, you know well, investor-backed ambulatory services, all kinds of money flowing into roll-ups of doctors in various ways. So there's new ways in which physicians are coming together. And let me just, for the hospitals out there, say, in terms of your journey to value, this is a chart you may want to think about as where am I on this journey? Thank you, sir. Thank you. I believe for some time that the PowerPoint was ahead of the reality. And so we came up with a scale a few years ago. And what is based, and we're interviewing hospital CEOs or leaders in this survey. About a third of hospital, and the way to think about this is not hospitals, but hospital beds, because we weight it by bedside. So 30% of the beds in America would say we have no plans to take risks beyond modest shared savings, right? Another 28% saying we're experimenting with risk arrangements, but it's a small part of revenue. So we're dabbling, right? If you go to the other side of the chart, the extreme version is we're committed to moving the majority of revenues to fully at risk within 5 years. That's a high bar, and very few people would agree with that statement. There's another 9% say that are building an ACO model capable of taking risk, such as Medicare Advantage or employer direct contracting. So I think most people are still back somewhere in the middle or at the beginning of this journey rather than at the end, and that's kind of consistent. But if you are in the risk business, what you're going to stumble across very quickly, and the insurers in the room know this well, that in any insurance pool, and this is almost like a law of physics, 5% of patients account for 50% of costs. 1% of patients account for 20% of costs, and the healthy 50% use next to nothing, right? If you're an insurer, you want to hang out with those 50% people. If you're a provider, you have warm and fuzzy relationships with the 5%, right? You're behind the 8 ball if you suddenly say, I am an insurance company now. And that's what I worry about. And when you dig underneath that 5%, what do you find? It's Hondas, we defined earlier. It's behavioral health. It's in the elderly population. It's end-of-life care. It's anyone with active cancer treatment in any population. It's frail elderly in the elderly population. And the solution set often looks more like social work than medical care. And that's the realization that's going off, popping. It's why the social determinants of health mantra is rising across the entire healthcare landscape. It's not a new idea. I mean, my mentor, Bob Evans, sort of fashioned that idea 30 years ago. But it's certainly getting more credence. And the other one is specialty pharma. You prescribe one drug, one biological drug, then you'll automatically be in the top 5% most expensive patients. Now, let me just say a couple of things about rural health, and then I'll close with some chance to have at me here. Sorry, I'm doing too long. Look, I won't go through all of these. You know this. Rural health has special challenges. It's dominated by public coverage. It's under scale. It has difficulty attracting people. Capital and equipment is old. It's tough to measure quality in small numbers. But what I would say is the solution cannot be send checks and leave us alone. I was trained as an urban planner. I totally get it that if you close the typical rural hospital, it's the end of the community, right? It's the one thing that's keeping them together in terms of an anchor and an employer. So my starting point is you're not closing, you're changing, right? And I think we need to have that change conversation. And it's going on all over the country, right? And some states are doing it better, and some systems are doing a better job. There's approaches like Mayo or Avera in the Dakotas who have sort of outreach and a lot of telehealth support. I think you look to things like the hub model that Kaiser's built in the urban environment that could be applied to the rural environment as a sort of ambulatory center. You can think of ways in which the rural hospital could be converted to a community-based continuum of care center for the chronically ill with a lot of support and a couple of helicopters. And of course, the interest that many of the big systems have is the referrals that are engendered from it. But I think the principles of redesign, and I'm not smart enough to prescribe exactly how you do this, I just suggest you have a conversation about it, is I think you have to use telehealth and digital health wherever possible. You have to think about much more regional cooperation on quality improvement. You have to think about payment reform, trying to get towards sort of field-based capitation rather than some tricked-up fee-for-service model. And the rationalization of clinical services and cooperation amongst regions, I think, is going to be critically important and require new partners and new thinking. So where are we going to end up? Well, look, I think we either get a system of integrated care that is supported on a bipartisan basis, as I said earlier on, that really builds off of Medicare Advantage and Managed Medicaid and engages large integrated delivery systems of different flavors in a future. Or we're going to have what I would call medical Darwinism. Everything looks a bit like Texas with 20% uninsured, 50 million uninsured again. And basically, the best care in the world if you can afford it. I think the single payer story is a bit of a fantasy in pure form, but I do think unless we get this value train on board, then you are inviting price controls and budget controls from the top down. That would be my counsel. So I'm going to skip these three scenarios, but let me just, I'm going to go back one. So what do you do? Well, I would say you focus on getting the cost structure down in healthcare delivery. It's easy to say, it's really hard work. There are some hospitals who are making money on Medicare, not many. And they have a fanatical cost discipline. And there's all kinds of ways to do that. I think you have to end up partnering for risk delegation. I think it's hard for somebody who's not an insurance company to become an insurance company and do it well. But it doesn't mean that you can't partner and align incentives. And there are vehicles for doing that. I think we have got to get much, much, much better in understanding those 5% of patients that account for 50% of costs and designing care delivery models that meet their needs, not meet our needs as providers. And then I think there's a whole rethinking of scale going on in the industry. I don't believe you have to be a $30 billion health hospital system to survive. I think that's nonsense. I believe you need to be big where you are and in your local market. But I don't necessarily believe that there's a scale effect up beyond that. And, every market's different. My good friend Jeff Goldsmith talks about terroir, and I think every market's different. So what can you do here in Idaho? Back to the beginning, expand Medicaid is a good place to start. Embrace value-based payment in all the different flavors, and you have the right people in the room to figure that out. I think you need to get serious about value by working on unit costs. I think this industry generally has been way too focused on revenue and not focused on cost reduction. I think we need to focus on cost reduction seriously for once. And I believe in Americans' ability to innovate. And I think there's lots of room to innovate in terms of telehealth, in terms of scope of practice changes, in terms of primary care redesign, in terms of thinking how the burden on ERs can be lightened by improving urgent care and other forms of less extreme emergency room operations. Harnessing retail partners from CVS to Amazon, focusing on social determinants of health, and strengthening and integrating behavioral health, as the governor talked about earlier. And I would just say, if there's one word I would take from this, and you've got the right people in the room, and you're going to hear from distinguished colleagues in the panels that follow and the presentations that follow, is think about partnership, not about conflict. There really is an opportunity here in a state like Idaho with a common spirit of cooperation to actually work this out. And I've often talked about what I call the mutual disrespect problem. Everybody in American healthcare thinks everybody else's job is easy and anyone can do what an insurance company does. That's not true. Everybody has something to contribute to this, and I would just say it's in your hands. Have at it. And have me back in 10 years, Roger, when you've figured it all out, right? Okay, let me stop there, and thank you very much for your attention.
We have a question from Pocatello, or from someone here who didn't want to have to stand up. Question is, Dr. Morrison, I am seeing more and more private employers offering employer coverage that pays all inpatient claims based on Medicare reimbursement. The plans are commonly referred to as reference-based pricing plans. The plans reimburse the hospital at some multiple of the established Medicare rate, 140 or 170% of Medicare. If a hospital is not willing to accept the reimbursement, an attempt is made to negotiate a settlement with a maximum settlement ceiling being set at 200% of Medicare. Do you think these plans will survive, and do you think they will succeed in reducing the costs of health care?
They will proliferate, in my view, and I think some of them may be backed up by force of law. I mean, if you look at the Washington State example, their public option is essentially arguing for 170% of Medicare as the pricing rate. And remember, what they did as a lever is they included their state employees in that program. And that's the thing to think about, is whose muscle are you going to bring to this party? Because Medicare has the obvious muscle, and can a commercial payer really invoke that muscle? The short answer is probably not, but if they do it in concert with, say, their state employees. I mean, I don't want to be indiscreet here, but I was on the phone with my colleagues at Kaiser. They're freaking out about this thing because they may have to walk away from 50,000 state employees because they probably don't meet that threshold of 170. So the short answer is that what the questioner is describing is a perfect example of what I said earlier about the warm comfort of Medicare pricing. You're going to see more and more people trying to do that. Whether they have the juice, the clout, the ability to force that down a provider's throats remains to be seen, but some markets over others, it will be possible. Especially if it's north of Medicare reimbursement rate. People will take it rather than not. Pretty depressing, eh? Anyone else got a thought? Yes, sir.
So we talk about Medicaid expansion. You have Medicare seems to be growing. Physician burnout. What's your opinion of still having providers that elect to decrease that from their practice? Even though we create all these programs to give to people, you have providers that those are the types of things that they're limiting from their practice.
What, you mean saying that we're not going to take any of those?
Yeah, so you have Medicare. You know, these patients are sicker. They take more health care attention. You have the Medicaid, which you listed on your slide was the neediest. Right. In some areas. It's the lowest reimbursement. They're going to take the most time. And yet you have providers that are now limiting or have been limiting. So now we're going to redirect the patients back to the hospital in the most expensive version of ER visits.
Right. Oh, I see what you're saying. Yeah, right. So it's are we talking primary care or specialty care providers, or both?
All care.
Yeah. Right. Well, look, I'm on the board of the Martin Luther King Hospital in Los Angeles, in South Central LA. It was a hospital that was closed through malfeasance about a decade and a half ago, and came back from the dead as a public-private partnership, where an independent board basically. But we survive on special deals at 3 levels of government. I mean, we are being basically financed by the county, by the state, and by CMS with our own special deals. And I think that's actually where we're going to end up in some areas of the country, is publicly financed delivery models for the very reason you're talking about. There's no EMTALA for doctors, right? There's no requirement that doctors see any patient that walks in the door. And so they have the choice under current law to just simply say, no, I'm not seeing those folk because it's under my target income rate or reimbursement rate. And yes, you're absolutely right. You dump that back on the hospital. That's why in California, we've seen a 40% increase in ER visits in the last decade. 30% increase adjusting for population growth. And that's pretty true in a lot of places. It's because people don't have a regular source of care. So I think we will respond to it. And I think there are, look, I feel for people in that environment where you basically are getting less and less for more and more challenging patients. That's why I'm a believer in finding ways to use new technology, innovation to amplify. Like AI, I think, is going to end up being hamburger helper for doctors, right? It's going to make things go a lot longer as our nurse practitioners. And we are training nurse practitioners at a very dramatic rate. And I think we've got to harness those practitioners and technology to do that. I'm working with a group from the UK are coming over here who are telehealth-enabled primary care service with AI. And in the National Health Service, they are now allowed to be the primary care carrier of choice for within the National Health Service in London. And they have 50,000 patients already doing that. I think you're going to see more and more of those kind of technology-enabled practice solutions come forward going, in the next decade, for all the reasons you laid out. Yes, ma'am.
So Idaho is getting Medicaid expansion January of 2020. We're very excited about that. It's been a long journey. Where does that put us in the trajectory of transformation? So when you see other states who have a lower uninsured rate according to your map, and they're working on all of the things that are also on our list, how far do you think that puts Idaho? What should we be planning as far as our trajectory of transformation?
Well, I would turn it back and ask you all, what's your goal? Is your goal to cover everybody? Because if your goal is to cover everybody, then the slivers of remaining uninsured will be undocumented folk, will be people in the coverage gap, who are earning less than 100% the federal poverty level. If you don't expand Medicaid to all populations. So it will be the people. I mean, I was in Arkansas a couple of weeks ago. They put in a work requirement. 18,000 people lost their Medicaid coverage. So if you make it more difficult to get in, you're going to see you're still going to be behind the eight ball in terms of coverage. I mean, we basically have universal coverage in Massachusetts now. And if you think about how long it took for them to do it, they have a very sort of extravagant, I would say, Medicaid program, and they have an aggressive exchange and significant subsidies to maintain and eliminate coverage, and they have a strong economy. So it can be done if your goal is to get to 100% of coverage. But that's a political and moral choice, as Uwe Reinhardt would say. It's not a technical one, in my view. There are ways to do it, and some more expensive than others. Yes, sir.
Thank you for the illuminating presentation. I have a question. With all the great ideas and things that could be done to improve the way care is delivered, I'm trying to see if you have some ideas or some comment regarding how do you develop the workforce needed to implement all these great ideas and provide the care. Do you have a comment on how the workforce could be developed, particularly in rural and underserved areas? I'm talking about training.
Yeah, I think that's a really important point. And I think one of the things, the workforce at all kinds of different levels. I mean, I think, there's a number of initiatives to train. For example, Kaiser has started a new medical school that will be graduating, started the starting class this year, this coming year in the fall, because they are looking to train a new generation of physicians that are more attuned to what they believe a delivery model of the future looks like. There are other universities who are doing Hofstra with Northwell in the East Coast who are doing that. I alluded to the nurse practitioner opportunity, I think is a real one, and one where we're training more and more people who are capable of providing new ways of organizing care. But I think there are other investments we got to make in things like community health workers, less skilled people who can take some of the burden off of higher skilled people, and people should be practicing to their top of license. And I think we've got to conceive of new assistants, medical assistants in healthcare, both electronic ones and real ones, people, to advance that. So I think this is, you're pointing to a critical part in the transformation journey, is to make sure you've got a workforce that is plug compatible with that emerging transformation. I completely agree with that comment. Yeah.
Thank you.
We may be at the limits of human biology here. I'm gonna take. Let me just make one final comment, and I think the governor alluded to this in terms of the whole issue of lifestyle and wellness and health. And I'm always reminded, if you look, I'm a student of international comparisons in healthcare, and the one country that keeps coming back over and over again that does really well on measures is France. Right? And I go to France a lot, and I'm very familiar with the French system. It's pretty scruffy, I have to tell you. But the reason France does well has really got nothing to do with medical care. It's because they walk, they drink red wine, and they get naked in the summer. And nothing will keep your BMI down better than getting naked in the summer. So thanks for having me. It was great to be here.